All right. Hi, James.
Hi, Liz.
So thank you for agreeing to do this recording with me for the PWP trainees at Bradford. I'm really grateful for your time. Would it be okay for you to just introduce yourself and tell us, who you are and why you're talking to me today?
Yeah, so I originally trained as a PWP in 2016, and then went on to be a PWP supervisor. And then I've spent the last 3 years in the final leg of training as a counselling psychologist. And part of that, I've been sort of trained in 3 therapy modalities, so humanistic, CBT, and psychodynamic. And I've also been doing guest lecturing and marking for the first year of your course at Bradford.
Yeah, thank you. So you're basically covering all the bases there in terms of theoretical models, aren't you?
Kind of.
Yeah. So we're talking today about on the competency grid that we're using at Bradford. We're using the competency grid for low intensity work that was developed at Sheffield a few years ago. And we're talking today specifically about the skills that are listed on that grid as engagement and interpersonal competencies. But really, I think what we're talking about is what's the role of the therapeutic relationship in low intensity work, aren't we? And what are the skills that you use to build that, and how do you use that well to deliver good low intensity work? That's my take on it. What do you think?
Yeah, I think, yeah, absolutely. And I think the grid is twofold. I think it helps markers as a guide, but I think it can help trainees as a guide as well. But I think thinking back to we used that measure when I was training, and I think one of the pitfalls I fell into was seeing it as a bit of a track to go through, a bit of a script, which can be problematic.
Yeah, so no scripts.
Definitely no scripts.
There has to be a structure though, doesn't there, to a low intensity session? How do you find that balance?
And I think that's where the measure can be used well. So it being around that being some people use crib sheets and things, but I think you look at the sections and what's involved in those sections, instead of going through and trying to tick one off after the other and say, well, I've said this, so therefore I've met that. I've said this, I've met that. But actually, it's done in a logical flow for an assessment. So you look at the opening structure, which is about setting the scene. So it's really about that opening. The very first section, which is about these sorts of introduction, competency, and then the subsequent adherence to the agenda. So that's basically how, as a patient, what do I expect? Most people will be very anxious. Any therapy session, assessment, or whatever, are going to come, or an insurance call, anything, where you're going for the first time. There's going to be a natural level of anticipation or anxiety. So if people are already anxious, it just gives that little bit of certainty or a bit of assurance about what to expect. Yeah. And I think part of that is informed consent. So, session is going to take 30 to 45 minutes, depending on what it is that you're doing. And we're going to be covering this, and this. But also, what does the person want to get out of it? Is there something burning or, it's very specific that they want from the session? So it's about informed consent, isn't it? This is what we're going to be doing, and this is what we're agreeing to do. Is that okay? Is that something you want to do?
I mean, a bit of a prop for the video today. I have got my paper copy of Reach Out here. I've got the page open there that sort of talks about the assessment session that low intensity practitioners offer. Thinking about the common factor skills, which I'll come back to in a minute. But one of the things that notices on there is being able to establish relevant expertise, which I think ties in with your comment there about giving informed consent to what's happening in a session, is being very clear about who I am, what are my competencies, what am I trained and employed to provide, and do you agree to work with me within that limit, isn't it, a little bit? Does that sound right to you as something that you've got to be able to do well as in any kind of therapeutic work?
In any, it's about informed consent. I mean, you can't, there's got to be reasonable. It's got to be done within a reasonable margin, hasn't it? You know, you can't just sit there for the first 10 minutes and say, I don't know, say for example, you're going to be working in a different service, or sit there and say, you know, I'm this type of therapist, and type of work I do is really looking at childhood trauma, you know, and you're going to really sort of overwhelm somebody or put somebody off, aren't you? I mean, there's going to be a limit to what you do. But I think actually saying what you do as a therapist or low intensity practitioner, whatever modality you're working in, is actually what my role is with you, is to try and explore and understand a problem that you're coming for help with. That is that's trans modality. You know, you've got trans theoretical, it goes across all the modalities. The person has a problem. When we identify and help the person identify what the problem is, and can the problem be helped with what I offer as a clinician, and if I can, what that might look like.
Yeah, oh, that makes a lot of sense. And I guess with the assessment appointment, what we do as PWPs is we're trying to get that definition of a problem and work out if we can help somebody with it or not, isn't it? And we've got pages of lists of skills that we use to do that, different ways of asking questions, ways of formulating and conceptualizing that problem. But what we're talking about today isn't so much the what we do as the how we do it, isn't it? And I think, to me, that's what those 2 pages on the competency grid are about, is how it's the skills that speak a little bit more to who we are as people, isn't it? Our warmth, our attitudes, our judgments that we make, our willingness and ability to share power, our willingness and ability to listen well and understand accurately. And I think it's the how, isn't it, that we're talking about in this video specifically.
Yeah, and I think that really links into also, and I think is less explicit, is less, again, it's not so saying it's a criticism of trainings or the role, but I think often what's less explicit is why.
Yeah.
I remember myself as a trainee not really sort of understanding. I used to criticize it. I'd sort of say, oh, there's this great big long pro forma that I've got to go through with 1,000 questions, and it's all in this time, and that isn't person-centered, it isn't this, it isn't that. And it's a common one, amongst trainees. And I think understanding why those sections are there. So what is the function? What function do they serve? Yeah. And it's a guide rope. So it's, you know, if you think about the marking grid or the competency measure is a guide rope. Nobody's going to go from one end to the other absolutely in perfect fashion all the way up. You know, there's going to be patients where you'll spend a bit more time here or you'll need less there, but you know that you're not veering too far away from it. You know, we're getting into what would be, so as trainees, you know, or people that are watching this video now, we're likely to be at a relatively early stage in training, I would imagine, if we're talking about the assessment OSCE. But thinking about clinical drift as you get further into training, that actually clinical drift, there are very good reasons why we're sort of against that, you know, trying to really limit it and contain it, when it's not the purpose of the video today. But again, back to that, what we do and how we do it, but also being a bit more explicit as to why. Yeah. You know, why we don't do a particular thing, or, you know, what the function is of that particular section, and what the importance of it is. Yeah. I think I don't know, from a person perspective, I can get much more behind. I buy into it, you know. I'd be a bit far more enthusiastic about something that I understand and understand the value of it.
Yeah, I agree. We definitely don't want to just be saying do this in this way for this long and create kind of uniform robotic practitioners. That's not the idea of what we're trying to do, is it? I think I'm going to pick up on what you said there about drift, because I think I've got the marking grid in front of me actually on the screen, and I'm reading through those 2 pages and looking at these are the skills that are used to build a good therapeutic alliance or relationship, aren't they? Empathy, your non-verbal behaviour, how you sit, the tone of voice, your expression, all of that, how encouraging and reinforcing you are, and I suppose what you choose to encourage and reinforce, warmth and compassion, the pace of the session, collaboration, being able to share power, simple and complex reflection, the use of summary to structure and make sense of the information that you're given, and the balance of you talking and the patient talking are all captured in these in under those umbrellas of interpersonal engagement competencies. And when I think about these and what we call it's what Reach Out calls the common factor skills, those skills and ways of being in your work that cut across all of the therapeutic modalities. I think one of the differences between a PWP and a person-centered counselling for a counsellor, for example, would be what those skills are supposed to do when you work with somebody. Does that make sense? So for a counsellor, they call them the core conditions, don't they? Unconditional positive regard, empathy, genuineness, congruence in yourself and with your patient. They're fundamental to person-centered counselling. And actually, in that approach, they'd be considered essential and sufficient for change, wouldn't they? That if you provide an environment where those core competencies are in action effectively, that would be enough to produce good therapeutic change in your work with somebody. I'm not a counsellor.
Neither am I. But yeah, and the only thing I'd add to that, so I think the core condition, I think when we talk about core conditions, I think the very generic human principles, really, that you're sitting in a room with somebody, that you're being, the congruence is really about, for me, are you there because you want to be? Yeah. As a PWP, that I think is an easier way to think about it. Am I here because I've got an agenda and I want to get through this, and that's because I'm getting paid and it's my job and I've been told I've got to do it. And your agenda being, well, somebody needs to be diagnosed with this and on this pathway, and they have to be because that's all I know, or that's all I'm trained in. That will be incongruent because you've an incentive, haven't you? That you, again, it's where you bring it into power, where you're going to be doing something to the patient, rather than it being shared. I think the thing about collaboration, which is, not to get too complex with theory, but thinking about the difference between person-centered counsellor and, as I understand it, and PWP, is that it's done in the opposite way round. So those core conditions about being human and sitting with the person, but person-centered counselling is where you're led by the patient. So a patient might come and you might talk about all sorts of different things through that session, but it's the counsellor following and monitoring the process of the patient, whereas for a PWP there's an agenda, in terms of it's a bit more CBT orientated. So it's about, for me, that's about efficiency of the time of the session. So let's try and narrow this down to a core problem. So I think how you meet the patient is very similar across all modalities. You all those core conditions and the common factor skills, but I think one of the real skill sets with the PWP that gets overlooked or is not as pronounced, I think, or given as much credit, is that the skills that are taught are there to try and be able to help somebody take a lot of information, a lot of anxiety, a lot of feeling of overwhelm, and to contain it and help somebody to speak about the main core thing that they're really wanting some help with.
Yeah. Where I was going with that, I think I agree with everything that you've just said there. I was thinking about how in other approaches and other ways of working, those kind of common factor skills are a significant part of the change method, whereas for us as PWPs, the function, what they do for us, is a little bit more about facilitating access to the change method. So we're not working with the relationship to produce change, we're establishing a relationship to help a patient to get access to a certain set of ideas and principles that we can support them to use to produce behaviour change that will hopefully have the desired effect and start to resolve that problem. So for us, those core conditions, those common factor skills are necessary, just as in the other approaches, but they're not sufficient for change in low intensity work, because the balance is different, isn't it? How they're weighed up against other aspects of what we do is different.
Yeah, it becomes interpersonal, I think, with counselling or more dynamic therapy, but you'd still have challenge within it. It'd be different. It's just a different set of techniques.
Yeah.
I think being in a room with somebody and that being sufficient. I think even counsellors would the counsellors I know would sort of say that's maybe not quite enough. There's other intervention that's done between two people. So it's the relationship is used as the tool, really. But the main, I guess that's the difference between an alliance, a therapeutic alliance. So of all modalities, that's about two people in line with each other. Are we singing from the same hymn sheet? Are we on the same page? And are we really the collaborative, I think, which is a really key thing, certainly with CBT based, is are we actually working on the same thing?
Yeah.
What are we agreeing on?
Yeah.
That makes sense?
Yeah. Yeah, it definitely
so I
does.
think that whether it's person-centered counselling, whether it's PWP, I think there's two things in operation. One is the relationship, which is about two people meeting, the alliance, getting on, being able to work together, and that being human and empathic. And then the next layer up, the dual bit, which we're talking about sufficiency for change, is intervention. And I think one's done through the relationship. With PWP, it's done through healthcare technology, workbooks, psych ed. Yeah. More CBT, where you've got, so the two, I think in any models, the two have got to go hand in hand. I don't think there's ever just sitting.
Yeah. No, that makes sense. Thank you. But do you agree with me about that idea of the balance of these skills in the work that you're doing with somebody? Does that sound about right?
Absolutely.
Yeah.
And I think also the importance of the boundary. So where it is about low intensity, where you're going in, building an alliance and it being a human to human relationship, and then your intervention is technique based, as opposed to the technique being relational. I know that's going to sound really sort of slightly woolly, but that makes sense. The boundary is about the alliance, not where you're going over that and trying to draw on very sort of large emotional expression, and you're doing exploration and all of that. You with PWP, it's really about the what's happening right now.
That makes a lot of sense. I guess what we're saying really is that as a PWP, you need to be able to establish a rapport with somebody, to build a collaborative alliance where you're both pulling in the same direction. And we're talking about the skills that used to do that, but we're saying that's got its limitations in this way of working, that we're not going to go beyond that and start to have an emotion focus in the work that we do. We acknowledge the emotion that is part of somebody's experience, but we're not focusing our work on that, and we're going to supplement or use that alliance as a way of accessing specific techniques and packets of information that are what we deliver, aren't they? And the alliance kind of facilitates and supports access to that, and behaviour change as the desired outcome. So I wonder if we could get a little bit specific then. I think there's some sort of big items, like the big hitters in this part of the skill set that we're developing. There's empathy. I think the use of reflection and summary. There's something about that balance of who's talking in the session, and the balance of what you hear. And something about the pace of delivery as well. And I think all of that's kind of covered in here. Should we start with empathy? Because I think that's the one that a lot of people get confused about and do either really well or really badly, don't they? And we've seen both. So could you tell me what you think about empathy in PWP work, please?
I think of empathy. There are lots of different sort of ways that it can be framed or thought about. But I think specifically for PWP, it's really about trying where you can, because it's not always entirely possible, but trying wherever you can to put yourself in the other person's shoes. And if you can't, so if it's something that you've not experienced before, or you've got really brief example might be, so I don't have children. I have nieces and nephews, but I don't have children of my own, so I don't know, and I'm also a male, so I don't know what childbirth is like, or I don't know what raising a very young child, or the fear associated with it, and the anxiety, when you're bringing a newborn home and all of that. So I have no idea what that's like. I can have some ideas about what it might be. I imagine it might be quite frightening, but the way that I would find that out is by saying to my patient, you know, I've no personal experience of that, and I can't imagine what that's like, but I'm really interested to hear how you've experienced it. Can you tell me a bit more about it? That to me is empathy.
Yeah, yeah. So it's not necessarily feeling what the other person's feeling or having all the same experiences that they've had, or even sympathizing with them, is it? It is more about a willingness to understand what it's like for them.
Yeah, and it's tied very closely to compassion, so willingness to suffer alongside. I think that, you know, and I don't think you have to get too sort of getting into, so we need to demonstrate compassion, we need to demonstrate empathy. I think if you are kind, you're interested in the person, and you treat somebody as a human, you're going to naturally display empathy and compassion.
Yeah.
I think if you really struggle to display empathy and compassion generally, possibly this is going to be the wrong job. I think full stop. And psychotherapy generally, I mean, I'm putting it out there, but you know, that's something to bear in mind. But I think the majority of very, very rarely will we come across somebody with an inability for empathy and compassion. I think what the most common problem I see, certainly as a marker, is anxiety gets in the way of it.
Yeah.
The compassion zone anxiety. So it's just going to be there. That's a natural level. You under examination conditions and everything. I get, you know, we get that. But where somebody is so focused on getting through everything with the timing and trying to monitor their own anxiety and thinking about what's happening for them and will they get something wrong, and we, you know, very much sort of inward thinking, very much focused on self. You're not focused on your patient.
Yeah.
So I think empathy, compassion, where it's focused on the patient, focus on their needs, trying to understand the other, you're naturally going to bring your own anxiety down.
Yeah. Yeah.
Does it make sense? Because it becomes external. I'm not trying to get too sort of theory heavy, but, and I think that's the main thing that I would spot. And you can tell, so it might be in where somebody might be, I don't know, saying something really old. COVID pandemic's been massive, hasn't it? I mean, we across all steps of the healthcare system, we've seen people with the results of that. And it might be where somebody's got it and the relatives got COVID and they're very, very upset and you know, sort of distraught about it. And you might hear somebody say, yes, it sounds like really difficult for you. When that's happened, and then they're over here on something else, you know, this sort of, there's a bit of a validation, kind of, and then it's used at the sort of this thing about feeling difficult. It's used as a filler to something else. So in that, as a marker, what you can hear is that there's, you know, you can hear that somebody's expressing something that is likely to be distressing at a human level.
Yeah.
It's only partly acknowledged, and then there's the sort of the time element comes in. So you almost hear a trainee kind of using it as a way of moving on.
Yeah.
Shutting something down and moving on. Oh, that sounds really difficult for you. What about this?
Yeah.
That makes sense. Whereas again, in those circumstances, it would take 10, 20 seconds to say, from the majority of people I've been working with that have got relatives with COVID and through the pandemic, you know, it's incredibly hard. And I imagine that must be incredibly hard for you.
Yeah. And
must be impacting a lot in, you know, in terms of your experience.
And in a way, I suppose what you're doing is you're taking a bit of a guess at what that experience is like for that person, aren't you? But you're doing that in a curious way. Yeah. You're not saying you must be feeling X, Y, and Z because that's what I'd be feeling. You're saying, with all of the information I've got and what I'm seeing, this is what it sounds like. You're showing willing, aren't you, I suppose?
Yeah, absolutely.
With a bit of curiosity in the mix.
And just touching a little bit what you were mentioning earlier about the kind of feeling somebody's experience. And again, it's trying not to, there are different theoretical explanations or versions of what people think empathy is, which is why, again, we sort of point that out, because being able to feel somebody else's emotions depends really, again, on which the theoretical position that you would come from. But it's so, if you've experienced something that might be tapping into your own stuff. So say, for example, I don't know, somebody has a pet that's passed away, or a pet that's died, a cat or a dog. And the trainee that's working with somebody has also experienced a loss of a pet or cat or a dog, and they get that feels awful, you know, really upsetting. So the person's saying, the patient's saying on the phone, I recently had a cat that died, and the express, you can hear in the voice that it's, there's cracking in the voice, the sound, there's lots of emotion being expressed. And a trainee says, it sounds like you're expressing, some feelings of sadness there. So I mean, that would be a very classic sort of empathy expression, because you're tapping into your own stuff, what you might be feeling, what is resonating for you, and it's a good guess. Yeah. Is what you're saying, isn't it? Where you're doing the reflection, you're doing a good guess, but also hold that open that it might not be right.
Yeah.
The person says, actually, do you know what? wasn't really bothered about the cat. I'd only had it a week, and it was looking after it for somebody, a neighbour. It was more that it died while I was looking after it, and I found that the neighbour's going to be really upset with me, or the neighbour will be really upset. So, always be prepared for that might not be the case. But what you're showing, as we were saying earlier, is that you're really trying to get on board and understand what it's like for somebody, but you're also open to, because you want to understand it, for them to correct it.
Yeah. And I think I just want to pick up on something that you did there, because that was going to be my next question. Was I've very often observed that overlap between the use of reflection, like verbal reflection and verbal empathy. Mm-hmm. And there's a lot of crossover between those two sets of skills, isn't there? Yeah. And you did it there. You kind of said an expression of empathy might be verbalized as a reflection. So is it all right? I mean, I think what we've done is we've offered a bit of an explanation of empathy and how empathy might look and be useful. What it isn't a little bit. Is it all right to ask if I can get your take on reflection then, the skill of reflecting accurately? So on the marking grid, it talks about very simple and complex reflection. Mm-hmm. And you've just pointed out that using reflection well can be a good way to express empathy as well. So there's overlap between the skills in this section, isn't there? Yeah. What's reflection then?
Yeah. So just to point out, so I think that's really what I was meaning before about where trainees will come at this marking grid and think there's just these great big tick boxes of things, that it's all so overly structured. But actually, as a marker, what you might be in 2 or 3 sentences interaction with the patient, as markers, we might be sort of actually recognizing 5 or 6 different areas of competency that are all combined within one. So, ability for reflection plus empathy, compassion, and they're all in that one sentence. It isn't just a tick box that we've got to go through and hear separately. So just to put that point forward, I think with reflection, I think there's a happy medium with it as a PWP. I think this is, again, not trying to sort of drift off too much into theory, but I think an inability to reflect, you can pick up really, really quickly as a marker. So where somebody's not, to me, is around about reflecting, understanding. I think that's sort of the first part of it, and also self-awareness, which is the second. And I think the two, so where you're doing a reflection, a simple reflection might be, for me, is clarity of understanding. That's how I would frame it. Am I understanding what it is that you're saying? And then the other way, it being about where we ask the patient to actually, we check their understanding. I think it's a really uncomfortable one for trainees often. When we're saying, so what did you hear me say there? Or could you just reflect back to me what we've just said? It can feel a bit like, it feels a bit like, do you really want to sort of ask the patient? It feels a bit impolite. So that makes sense.
Yeah.
But the purpose, so the why, why do we do it? Well, where people are particularly very anxious, I mean, with depression as well, but where people are very particularly anxious, they can really get all up in the head, or really, really struggle to take things in, or really struggle to hear and listen. There's so much going off. Anybody that's had an experience of high level of anxiety, the brain doesn't function in the same way. So I think with the simple reflections, you've got clarity of understanding. So what I'm hearing you say there is this, is that right? Yes, or yes it is, or no, actually you've got that wrong. Okay, tell me where we've gone wrong. And then another reflection will so what you're saying is there it's actually this, is that right? Yes. So what you're doing is you're defining the problem in each stage of it, aren't you? And that's all reflection is. So it's putting a mirror up, isn't it? Sort of saying, okay, well, I've said this is the information you've given to me, let me kind of feed that back to you, and is that what you're actually saying? Is that what you're meaning?
Yeah.
And then the other way, where you ask the patient to sort of recap what's been said, is clarifying that they've heard what you've said. Because if somebody's very, very highly anxious, a lot of it might not be going in. Mind goes blank, or people forget or can't gather the thoughts. That's really, really, really common. So it's really about, for me, simple reflection is about clarity of understanding. And it's also, again, I don't know whether it's trained this way, but for me, it also helps to slow down and the process.
Yeah.
For people where they're struggling to articulate what's happening.
Yeah. I mean, I think just thinking back on some of my own experience as a practitioner and as a teacher, I think reflection's been a really helpful skill in terms of acknowledging the content that the patient offers to the session. And that can be the spoken content, but also the unspoken content. And I think reflection is how you validate, you make space for what the patient is offering to you. So there's that simple reflection of you just sort of almost just repeating somebody's words back to them, aren't you? You almost sort of say their words back, but not in a kind of condescending, repetitive, taunting way. In a, I'm hearing that, I'm validating, I'm acknowledging that way. And I think what I like to see is if a patient speaks, I think there has to be some kind of acknowledgement of what they've said before you ask your next question, especially in an assessment appointment, or before you start giving them more information. So somebody gives you some information or gives an account of something, and if your response is just a question, it hangs there really uncomfortably in the session. So I think just that simple, even just the repetition of the last few words that somebody said changes how something feels very powerfully. You've heard it, you're acknowledging it, you're validating it, they're hearing it back from somebody else, which gives them a different perspective on it. But then also sometimes there's that expression of emotion that isn't verbalized. Somebody gives an account of a loss, that example of my cat died, and they're not saying I feel sad, but the non-verbal information that you're getting says there's an emotion there that matters to that person. So there's an appropriate use of complex reflection, isn't there, where you say, and again, that overlap with empathy, sounds like that might have been really sad for you.
And I think as well, it stops or it limits, it doesn't stop it limits assumptions. That have been made on behalf of both the patient and the PWP. So it could even be on the where somebody's saying, oh yeah, no, I've had counselling before, and a friend said to have counselling again. So simple reflection might be there, is that, can I just check that so from your understanding, you think you're coming for counselling? Because what you want to be
because you need to know that, don't you?
Well, you check it. It's just used to really slow down that process, to digest in small bits. It's a bit like the summary, again, it links into the summaries. We do the section summaries. Those are there to help somebody clarify understanding in small chunks, digestible bits of information for learning to take place. It's one of the core underlying principles of CBT. I think you're touching on there about complex reflection, that can be used in really, really savvy ways, but will often, I always think, where you get simple reflection, complex reflection ties into compassion and empathy, that it can be done in a very clever way, or some people are very natural, but again, about where you're doing a simple reflection, but you're picking up on the non-verbal, so you might be hearing sort of break in the voice, or that somebody paused. So apply that to a risk situation. So saying to somebody, and have you had any thoughts about suicide or ending your own life in the last week? And somebody pauses and stammers a little bit, no. So your simple reflection might be, So you're saying that you've had no thoughts about suicide in the past 7 days. Complex reflection would be then, or leading into complex reflection, it just noticed as you were saying that there was a break in your voice and there was a pause, and I'm just wondering if there's perhaps more to that.
Yeah.
That makes sense?
Yeah.
So also what you're also doing is then you, and you might add on, it can often basically, you might have normalizing, you know, it can often feel very difficult for people to talk about this stuff, you know, for the first time. It can often feel quite upsetting on what's happening for you right now.
Yeah.
Actually, I did have this thought about it. Well, that sounds like that must have been really hard. And it sounds like it must have been hard to maybe talk to me about it today. Does that make sense? So it's, you think about just in all of these sections, the engagement, interpersonal competencies, and summarizing, reflection. There'll be lots and lots of opportunities that are happening.
Yeah.
Or where it's picked up, you know, where we're going up and down the grid and thinking, oh yeah, we heard that there. You know, it's not just about get that section out of the way, then do this and say a difficult, well, that's been difficult for you, empathic statement, and then I've ticked that off and gone to the next one. You know, it's very, very fluid process.
Yeah, absolutely. I suppose what we're capturing a little bit then is we're talking about the how the low intensity interventions are delivered, the who you are as a person in that process, how that's communicating itself to the person. We're talking about that willingness to get into somebody's shoes with kindness, with curiosity, that use of verbal competencies to kind of validate and acknowledge what's present in the conversation that you're having with somebody, breaking things up into smaller chunks to make what's happening digestible between you, and to get buy-in to how you're working, to enable somebody to get access to what we can offer. And after 10 years of doing all of that, James, I have become a compulsive summariser, which is where I want to go next. So can we talk about summary a little bit? So again, I don't want the conversation that we're having today to be too much about the competency grid, as in that tick box exercise of I must hear you say this, this and this. And what we're actually talking about here is when we're watching somebody's work, we kind of say it. These are the skill set that say, would I want you to work with a family member who I cared about, aren't they? That these are the skill sets that make a difference to that. These aren't tick box exercises and sort of phrases that you trot out. Oh, it's been so difficult for you. Now, can I just check? It's different to that, isn't it? These are the skill sets that I think make the difference between an effective low intensity practitioner and a robot a little bit. And so summary, I think, is a little bit less about the nice stuff, and it is a little bit more about kind of structure and progressing the time through the session, isn't it? Kind of applying what you're hearing to the theoretical model that you're working from, making sense of what you're hearing. What do you think?
Yeah, I think it's also about helping the patient make sense of what they're saying. So I mean, summary is used in all modalities, in one form or another, but for this is back to this thing about the why and the function of it. So if you were working in a psychodynamic setting, you might be using summary as what we call a recap. So you'd be pointing out what's happening right now, you know, and summarizing what's just been said and what happened. So, but doing that a lot, so people can get an awareness of sort of what's happening between the saying, the emotional body, and interpersonal action. Think about a summary in terms of for PWP, that you're capturing everything that's been said, roughly. I mean, not sort of word for word, but you're capturing the key things. So for me, what that says is, person's listened. So if there is a patient, I've been heard. Yep, absolutely. Yep, got that right. Yep. But also helps the patient to acknowledge what's already been said. You know, so where you get people, well, often where they're very anxious, so people with where, you know, we might think of them in IAP terms as generalized anxiety disorder, or where, you know, sort of worriers that will come and often will just express tons of worry right the way through, and there'll be hundreds of strands going off in different directions. I might think of that in a different therapeutic modality as it being a way of somebody managing in an anxious situation, you know, so that lots going off, and they become anxious and then express that through filling the entire session with words, so just talking over feelings. So what it also does, it allows that process to be slowed down. So, okay, because it's kind of in a way saying, you've already told me about this. Yeah. But also clarifying at each point, accuracy. Yeah. Did I get that right? So we've talked about this, and this, and that's what you've said. And can I just sort of check that that's correct? And more importantly, is there anything that you feel you need to add that's relevant to that?
Yeah.
Because the next bit we're moving on to, what we don't want to do then is to, we might make links. You might get people making links all the way through, but what we don't want to do is to try and we would want as a practitioner for the patient to avoid then repeating all of that stuff again and it coming back up, because what you're not going to get to is really the really important stuff that we need to know to be able to decide whether that person is going to be able to have what intervention is going to be the most suitable. Yeah. So both the practitioner and the patient, where things become very, very uncontained or not summarized, or it's just all a bit moving from one to another and we've got no memory of what we've said or clarity of it. The process isn't structured or slowed down, and what we can end up with is just it all feeling a bit messy and getting to the end and we haven't got quite enough clarity or the information to do right for the patient. They're not trained in this stuff. It's our role as a clinician to help the patient express what's really important.
Yeah. It sounds like without summary, you're not going to get to a shared understanding, are you?
No.
You can't. There'll be a kind of a flood of information from the patient. There'll be maybe some acknowledgement from us, but no making sense of it. And then you get to the end of the assessment with, oh, you've given me all of this. And as we've gone along, we haven't chunked it down, we haven't made sense of it. And now suddenly we've got to scramble to do that. And it all just falls apart, doesn't it? Yeah. So we don't want to see that. We want to see lots of making sense as you go along. Yeah. And that ties in with the questioning skills and the idea of funneling that's in a different part of the teaching. But
it also helps with cognitive processing. So it's not just about the slowing down, but it helps somebody to digest and to process what's happened, just then. And we've just talked about this. Have I got that right? I've been heard. I've got the right information. Get to the end. We're both in agreement. Everything, and because the whole thing's a funnel, really, isn't it? So to get to the very, very, very end and say, now, of all this information, we found this is really important to you. This is what you're struggling with. This is what I can offer. We're kind of in agreement here at this very early stage that this might be an intervention that matches up really well for you, and this is how we're going to do it. Then the person's got informed consent, and they've also got a choice, and they know why they're choosing what they're doing, instead of being passive, what I call a passive participant, which where they're just sort of PWPs talked endlessly all the way through, and patients given one-word answers, and then they get to the end and they say, well, and we're going to do behavioural activation, or you've got choice of silver cloud or whatever, and the patient's just like, whatever you think. I don't know. I've no idea why I would be choosing any of those things. That makes sense.
Yeah, it does. So summary, I think it's the jigsaw idea for me. It's you get one piece of the jigsaw puzzle, and then you kind of define the shape of that with a little summary. And then you get the next bit of the jigsaw puzzle, and your summary then talks about how those two bits fit together. You've got the two shapes and how they fit together, and throughout the assessment you're kind of defining the shapes of the pieces of the problem, talk about how they fit together, and so that like you've just said, by the end of the session, nothing's coming as a surprise. There's been a kind of logical building up of the picture as you've gone along, so that the outcome makes sense to everybody. So
it's an important, I think summary is the most, it's the one I always see people avoid. They might do one or two and just sort of pass, but again, that's more where you're looking at getting through rather than the function or why it's been done. It serves a very important purpose, and it can be said in a very natural way. We'd always encourage people to bring themselves to the appointment, not just saying it, as if you're sort of reading off an insurance call. It's perfectly okay. The more natural and the more, instantly you start hearing rapport, and you see somebody that's very natural with them. You can just tell generally that, the person's going to do well. Yeah.
And there's the difference. I mean, I know when we sort of talked about doing this video, we did say we weren't going to try to focus too much on the marking grid, because what we are talking about is these competencies are so important. Being able to understand and use these skills is so fundamental to good practice. We don't want it just to be about tick boxes. That said, the marking grid does break down summary into 2 tick boxes, and it sort of talks about capsule summary, which I think is what I've just described, as you get that bit of information and it makes sense to just define the shape of that bit and link it to the next bit. It also talks about major section summaries, and these are the ones that tend to make me want to cry a little bit, being very honest, where somebody will say, in our appointment today, we have talked about your problem, we have done a risk assessment, we have looked at your measures, we have done a 5 areas, and we have decided what we are going to do next. How does that sound to you? I've heard so many of those, and it really does, it upsets me a little bit, because that's just it's a tick list description. It's possibly accurate, but it's not meaningful, is it?
Well, it's not a summary either.
No.
It's more of a sort of session checklist.
Yeah.
So today we've done,
Yeah.
and ticking through. Yeah, I mean,
that's not a summary, is it?
No, and I think capsule summary, again, really links into the little simple reflections sometimes. Capsule summary could even be, have I heard that correct? From what you've said and I've said, and, there's overlap right the way through. But I think for me, capsule summary really is capturing a general essence or sense of something that's been agreed or established. Rather than the kind of reflection about might it not. Capsule summary for me is about being really clear that are we both in agreement that that's clear, clearly what's been said, or what we're in agreement on. The major section summary, again, doesn't have to be major. It doesn't have to be sort of like 5 minutes long where you're going through everything. A really important one would be for risk, say, for example, you'd be sort of just to clarify that you maybe had odd thoughts about suicide throughout the week, but what you're saying is at the minute that you feel you keep yourself generally well and safe, and but you've identified that there are people in your life that feel protective and that you would be able to reach out for, and you've got with the crisis numbers and all of the rest. I'm just wondering, out of all of that, I just want to check first that's the how I've understood it. I just want to make sure that that's clear. Yes. Is there anything, anything else that'd be important there? Because what you're doing with the summary is really saying, again, a bit like the sort of reflections is, I've heard what you're saying.
Yeah.
These were the key headlines. These were the really important things that came from you that I'm sort of checking out, but also giving you, is there anything that's been forgotten? Because every patient, we've done it ourselves. Again, I go back to the insurance call, they come away and think, damn, I wish I'd asked that, or I forgot to tell them this. It just gives that opportunity for clarity of thinking, but also clarity of understanding and an opportunity to add.
Yeah. I think there's something very specific about low intensity work as well, which is that it is a highly structured way of working, and it has to be. Like, one of the defining principles of low intensity work is that you don't have much time with somebody, so you have to really make every minute count, don't you? So the structures aren't there to be, they're not there to make you feel like you're in a coffin in the way that you're working with somebody. They're there to make sure that the best use is made of the very small time available with somebody. And so every session, whether it's an assessment or a treatment, has a recommended structure. There's sort of an order to things, isn't there? And I do think as a practitioner, it's very easy to get pulled into the content of what's happening there and then with the patient. You've already picked up on how as a practitioner, sometimes that structure can be a source of anxiety as well, that you can be a little bit in the back of your mind, just sort of worried, am I going too far away from my structure? Am I asking the right questions? If my supervisor is watching this, what would they be saying? If my marker was watching this, would I be getting my ticks? And all of that's kind of going on in the background and kind of hitting you physically a little bit. I do think the structures help to reduce some of that anxiety and keep the structure present but not oppressive. if you use them really well, if you kind of get that sense of chunking your way through that time with somebody. So in the assessment, you know, you've got your first little introduction bit, and then, you know, this is who I am, this is my competencies, this is what we're doing and how today, your safety in terms of confidentiality, how long we've got together, anything that feels really important that you want to prioritize as we're talking today, you know, any of that stuff. But then you go into the information gathering, which is you're sort of exploring that question with specific kind of questioning styles underpinned by all of these common factor skills that we're talking about. And there's a moment where logically you would want to just pause, bring all of that together a little bit before you go on to the next bit, which is maybe about risk assessment or formulating using a more formal model. There's moments where it just makes sense to just bring it all together, like look at how's this picture now before we build the next section, and using summary in that way as a way of pulling yourself back towards the structure and the good use of time, but also protective in terms of reminding the patient we've got an agreement on what we're doing and how we're doing it today, but also making that meaningful and it not just being a tick, 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 we've done tick, 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 but together, this is where we've got to, and now we're going to the next step.
Yeah, and thinking, just reminding about that it being a guide rope, and I think there's a really interesting point that also remembering where it's an assessment, that's exactly what it is. It's a intake assessment. I know I get some services do triage and then sort of more full assessments. It depends on the service setup, but an assessment is just that. And an intake assessment, if you're working in a CBT based service as a psychologist, my assessment's a 90-minute session, but it's exactly the same as the PWP, just with history added on.
Yeah.
What were you like as a child? Tell me about your early life. That will be the second half. Yeah. But the first 45 minutes, presenting problem in the here and now, risk, yeah, safety plan, thoughts about suicide now, thoughts about suicide in the past, current, you know, safety. What's the main aim for the person? What goals? What? Recording in progress. But there being, you know, so you required with an assessment, you would, and there's a difference between, again, this is back to drift, where there can often be a tendency for that assessment overruns, or where people get really sort of panicked because they feel like they're shutting the person down. They only want a bit of information and they're having to shut them down. But there's a real difference, and this is again the why and the function, because it's what it's to do is also in the assessment you need to capture a general sense. Is the presenting problem something that can be helped with psychological therapy, first off? But also, what is the problem and can we help? And we can only do that by getting an overview. We just need a brief overview from the person and it be contained. Can we help? And if we can, what does that look like? What are the options? Yeah, and about consent to do that. And I think what the risk is that you can end up into therapy or into a treatment session in the assessment, and that being a real, you know, something I used to think, oh, you know, these low intensity assessments, or they're just, you know, it's cutting people off and it's all short changing and it's just loads of tick boxes and all this. And then certainly working as a psychologist in any modality where you're doing an intake assessment, you still need the same information. And if you were to hear me do an assessment, you'd be able to hear each of those elements of that. It won't be sound exactly the same, worded slightly differently, or might be sort of approached slightly differently. But I could very much pass a low intensity OSCE within the first 45 minutes with any patient at any modality, because each of those components are in it.
Yeah. It's interesting, isn't it? I suppose we started off by talking a little bit about the differences between how these skills are used across different modalities, and you're saying there's some stuff that just cuts across any kind of therapeutic, kind of talking therapy, psychological work. There's some things that just stay the same whatever you're doing.
Skill set wise, yes.
Skill set wise, yeah. but and then we talked about, you know, in-person centered counselling. We use that as an example where there's more of a patient lead, and you just go where the patient leads. And I think sometimes people come into low intensity work and train as PWPs, having maybe wanted for a few years to be a counsellor, but not quite found a route into that. And drawn very often by genuine interest and compassion in people and wanting to help. And that sense of structure feeling a little bit anxiety provoking and alien. And what if it feels mean to the patient if I maintain a structure and don't go where they lead?
And I guess my counter argument would be, and if we spend 45 minutes just listening to this, you know, a very, very difficult thing, but leave them without a risk assessment, you know, or without any goals or aims, or even knowing whether the person's going to be able to access treatment or the appropriateness, have we done the person any favors?
Yeah.
Right, what seems very nice at the time isn't always in somebody's interest. And the other thing, if somebody was going, you know, I've never trained as a person-centered counsellor. It's I prefer sort of other modalities. But if they're coming to a service as an intake assessment, even a person-centered counsellor is going to still have to do an intake assessment, and it still covers those same domains. Might sound a little bit different or look a bit different, but they still need to know risk, what a rough idea of the problem and what the person would want to get from it. They're doing the sessions after that look, you know, in terms of treatment, look different. But yeah, when you think about assessment competencies, those are skill sets across all modalities.
Yeah.
And the core common factors across all modalities.
Yeah. And you're not shortchanging your patient by using those skills well within that structure. And I think Absolutely. If you can really believe that, your practice will be better.
Yeah. So I, to a really, really slight digress, but to give you a slightly different example. So I work in a neurology service, so it's physical health, but obviously it's a specialist psychotherapy service attached to a physical health service. So if you're going to see a neurologist, so before you go and do anything else, go and see the neurologist because you have a problem, seizures or whatever it is. What do you need to get? What do you need to get out of that appointment as a patient? You go to be diagnosed and tested and all of that, but what do you need to get out of that appointment? If you've got an hour, or you may not even have an hour, but say, for example, you had half an hour or an hour with a neurologist. The neurologist needs to know from you what the presenting main problems are that you're coming for me to look at, that you really want me to kind of understand and try and help you with. We need to know what the expectations are. Patient needs to be given information and a clear clarity about what's been happening, and that we're all on the same page, and a treatment plan, if that's possible. So if we said, actually, well, the person's been falling over and they've been having lots of neurological problems that we're not really sure whether is neurology or whether it's psychology, we don't know what the interplay is, then and that person has an hour with a neurologist, and actually at the end of it, all they've done is just focused on the amount of times that they've been tripping up or falling over, but not done anything else. Does the person feel shortchanged? That makes sense. There's always a flip side. I think and from personal experience, that what we can often do is get in our own head too much about, and this is what I'm saying about monitoring what's going on for us and our anxiety and what we're thinking and worried about. The patient might think with this or that or the other. We have no idea. And the good way you could find that out is actually with a probing question and a capsule summary. What did you hear me say there? So, can I just clarify that you were really upset with the fact that I really want to try and help you identify a problem and get you some treatment? Is that right? Did I hear that correctly? Yeah. The skill set's there, isn't it? I guess if you're really worried about it, ask. Yeah. How are you finding that? Well, we do want to hear you. I've been asking feedback. How did you find the session? Yeah. I think that, when in doubt, ask. Yeah, sure. Well, my rule it wasn't something I was taught as a PWP, but I think is across all modalities. If you've got a dilemma, you share it with the patient.
So you're telling me this, I'm wondering if this, what does that sound like to you?
Yeah. What are we in agreement on? Where can we agree? Yeah.
I'm thinking about some of the, and I think actually I'm going to pull myself back, because I'm conscious of the purpose of this video is a teaching session around the use of those common factor skills in low intensity work. There's so much that we could say. We could talk for hours, couldn't we? And we have, James. But as we sort of think about bringing this conversation to a close, this recording, is there anything that you would like our Bradford trainees to know about these skills and their use in low intensity work at this time? With all of your experience as a PWP, as a supervisor, as a marker, with that perspective, having worked in other modalities as well, what are your takeaway messages or top tips for our trainees?
I think the first one is you already have the skills. They're there because you're human and you're able to interact, and you wouldn't have got the job otherwise. You've got to go through a very, very long process to be able to get the job. So though that skill set is there, it's about getting it into a structure, that's going to be helpful for the practitioner, but also helpful for the patient, and trusting that that's there, but trying to see it as there being a function to it. There's a reason why it's done, and it's not to shortchange or to shut down. It's about it serves a very important function, and trying to bring yourself to that assessment session. So all that said, all the structure, all the function, all the whys, hows, all of that, the skill, I think, above all of that, is been able to take it and deliver it in a human way. So your own interpersonal, every person will have a different character, different personality style. Last thing we really want are robots going out into clinical practice. We really don't. What I mean by that is just where it's just going through the motions, or not genuine, just feeling very, very sort of tick boxy. So I think ease into the fact that you're allowed to bring your personality forward. To me, those are always always people that tend to do well, that are able to kind of put it into a structure, understand the purpose and the function of it, are empathic, and it's done very naturally, very fluid.
I suppose what you're talking about there is some warmth, isn't it? It's because we haven't spoken about warmth and how that can communicate itself, but
there's warmth, but I think also being real.
Yeah,
I think that would be, for me. I know it isn't in the Sheffield Guide, but I think being real. You're a person with experience, with life experience. You're sitting with another room that's in a room or digital surrounding with a person that's also human and also has experience. I think the last, what I would, if I give one top tip to avoid, would be the insurance call.
Okay, can you feel like say more about that?
Yeah. So today, John, have you had any experiences that would invalidate your insurance today? No. Okay. Any prior car crashes, any incidents that would potentially invalidate an insurance policy or future claim? I think no. Okay, that's great. So what we can also offer you today are tyre cover and an engine clean, and occasionally some of our customers find that it's scripted. You can really hear and feel where the sections are. So we've just got to fill out a few more things today, John, and then we'll be with you, and then we'll come to the next bit, and then what we'll decide, and it's, and you just, it being very, because that's a very detached way of doing it, isn't it? It's very, very, you could have a very lovely person that's in an insurance call centre that's just, saying things in a very nice way and polite, but you can really hear the fact that behind it is some form of, very, very structured process. And I guess what I've been trying to get across is, although it's structured, it's a guide rope.
Yeah.
It's there really to try and help as a practitioner to be able to do an effective assessment.
Yeah.
It's not the actual pro forma or the you know, the list and the box ticking that makes it effective. You as a practitioner are the one that makes it effective. It's just there to try and help you to make sure that you've covered everything that you would need to make an informed clinical decision.
Yes, yeah, 100% agree. We need practitioners who understand the skills, who can practice the skills effectively, and who can make good judgments about the balance of the different skills throughout a piece of work with somebody. We don't need people who can just read a script and who are trying to be identical to other practitioners and do things in exactly the same way that other practitioners do them, because at that point you lose a lot of what we've spoken about today then, don't you?
Yeah, and I think a common thing that happens then, this is from as a supervisor, is also as being, you know, an ex-trainee, that it could, because it's such an anxiety-provoking year, it can be really, really common that you hear people pick up how other people are doing it. They might be shadowing qualified staff. I'm sure there's some very brilliant qualified staff, but they might be shadowing some qualified staff that where they are being watched or observed, and it's a trainee, they think, oh, well, I'm going to have to try and show them how they did it at uni or whatever, you know. So it becomes performative, and you end up with somebody acting with a patient in a way that they wouldn't maybe do if they were being a bit more natural and not being observed. Does that make sense?
Yeah.
So what you then end up doing is the trainee thinks, oh, that's how you should be doing it and what should be said. So they then talk, you know, you can almost tell. You've mentioned it to me on many occasions, but we've done a video similar to this, but where the difference between something being very natural and something being performative. And performative will always be based on anxiety because the performance is about how the person's going to be viewed. So to me, if it's performative, the person's more bothered about what's going on in terms of how they're being perceived and what they're doing than what's happening for the patient. That really comes across then, and it knocks onto interpersonal competency. Those with an agenda where they're wanting to get through or do something because they want, I don't know, maybe have a thought in their head that to get through this OSCE and to get it, so I've got the pass mark, I need to have said this and got the patient to do this and this. Absolutely inaccurate. I mean, scrap that straight off if that's the thought. What your role is to try and help elicit the person's problem in the way they understand it, check your understanding, check their understanding, to be done in a warm, empathic way, natural, and that you're covering risk. And that, you know, providing all of that is there, it's going to come. If you're missing big stuff, so if you miss a big section, you fail a section like risk, you will have failed it for a very good reason, and it won't be because you didn't do it like an insurance call, or that you didn't say it in a particular way. It's because you haven't done a risk assessment. You know, there's sort of very dangerous things that have been left out, or things not followed up. You know, it's about clinical competency. It's not your ability to follow a crib sheet.
We've had some conversations in the course team about the difference between adherence and competency. And I think we really do want to have that emphasis on understanding and being good at what you do, and that doesn't mean adherence to a rigid pro forma. It means understanding the why and applying that well. And so I hope what we've recorded today helps with that in some way, that we've given some illustrations and some thoughts around that really, really, really important set of competencies, which are about the how you deliver a low intensity intervention, not just the what you do and the what you say. So James,
and common competencies that are also evident across all modalities in some way. They just look different.
Is there anything final that you'd like to say, or do you think we've covered enough there?
No.
Thanks.
Oh, good. Unless you have any other questions.
No. Thanks so much for doing this, James.
All right. No worries. Pleasure.